The following is a presentation of Project Independence and WCWP. Project Independence is the Aging in Place initiative of the town of North Hempstead. We provide programs and services designed to assist and support the older town residents who wish to remain in their homes as they age. If we don't currently provide a service, we will try and connect you to that service. Call 311 or 869-6311 to get more information or receive services.
Welcome to Project Independence and You.
Welcome to Project Independence and You on Community Talk Radio, 88.1 FM and WCWP.org. I'm Rebecca Miller, and along with a co-host is Otto Lohse. How you doing,
Rebecca.
Otto?
I'm doing well. Nice day.
It's not, yeah,
No
I guess
snow.
if you stay inside, it's a nice day. Also, we have our radio show producer extraordinaire, Christina Liu. Christina is going to be hopping on this first part of the show as well. Usually we just get her at the end, at the last hour when it's Talk of the Town, but she's going to help us out during this program today. Our guest today is Danielle Ezzo, and Danielle is an associate clinical professor at St. John's College of Pharmacy and Allied Health Services. So Danielle, thank you so much for coming on today. You're a definite friend of Project Independence. You've done a lot of programs for us. I think you even spoke at our Aging in Place conference at one point.
I did.
Right?
Did. Thank you for having me. This is always one of my most favorite events to do of the year. And I have done a lot with Project Independence. And I did speak at that conference that you're talking about.
Yeah, I know. It was great. It was a lot of information. I know that it was a busy part. People have so many questions. It's just so many, because I guess medication is always changing. I mean, everything from, dosage to advancements in medications. There's always that expense issue. There's so many questions that, we have concerning that. So, I was thinking like one of the basic questions that a lot of people have, and maybe we could just start out that way, is, maybe the difference between generic and name brand. That's always a pretty important question, because there's a lot of people swear by a name brand. Mm-hmm. And and I'm aware of times where it is changed to a generic that people really do feel like there is a change. So I don't know if you can just provide some clarity on the difference.
Absolutely. And Rebecca, I think you're right. There's so many different aspects of medication and medication use that affect everybody differently. You can have multiple people on the same medication and they feel differently on it. Somebody has a reaction, somebody doesn't have a reaction, somebody it works for, somebody it doesn't. And I think when patients or people talk to each other about medications, those things come up, and even more questions kind of arise. And especially this time of year when there's also the coverage issues. There's a lot of insurance changes this time of year. And I know we'll probably talk about that a little bit later, but that adds a whole nother layer of complexity. But your question about, the difference between a brand medication and a generic medication. A brand medication is, when a medication first comes out on the market, the manufacturer has rights to that brand name. They're the only ones that make that medication. There's no other versions of it out there. When a generic medication comes out, the active ingredient is the same. So the way it works in the body, it has to do the same thing that the brand did. What makes it different is the inactive ingredients, right? The things that hold the tablet together, or if it's not a tablet, it's a capsule, the colors, the dyes that they might put into it. But what it does in the body, it has to have studies to show that it's the same, that it does the same thing and has the same effects. And as more and more generic companies put out a version of that medication, that's how the cost starts to go down. When some medications go from brand to generic and there's only one generic medication, if it's 1 penny less, that's still okay. It's until many companies start putting out a generic medication that causes that competition, and it drives the cost of medication down a little bit. And most people, I mean, I am an advocate of generic medication. I know that's always something that I share with patients. From a cost standpoint, I mean, it creates cost-effective care. My parents, people in my family take generic medications. Where sometimes it becomes, I'm not going to say an issue, but like a higher time of concern is when it's a medication that, a doctor or a prescriber is checking specific levels. So like for a thyroid medication, when a patient, so something like Synthroid, I don't know if you've heard of a drug called Synthroid. I know a lot of people out there probably know that name. When you change from the brand to the generic, it's not that the generic is bad, but because the body is so sensitive to the changes, even a very small change in how the two medications, I don't want to say work, but the levels of medication in the body, that could change levels. So usually what I say is I encourage the generic medication, but you might need an extra blood check just to make sure that that generic is still working the same way the brand was, but only for those types of medication. And there's maybe a handful that I can think of. So if you're in that situation, or if patients are thinking like, well, how do I know if I'm in that situation? Ask your pharmacist. Go to the pharmacy, speak to them, and ask those questions. Those are good questions to bring to the pharmacy with you.
I had experiences over my life with cholesterol medication, Zetia. And Zetia, when I first started, I guess they have like 20 years that they have a right to use the medication where they can have a generic.
Really?
So,
20? Is it 20 years?
It's 17 from the time that they find the compound. So if the quicker they can get it to the market, the longer they have. But yeah, I mean, Otto's right with the 20-year mark.
Wow.
Well, I'm going to use round numbers, but Zetia at the time when I first started, it was like $400 for a 90-day supply. And then I learned, well, okay, I can go to Costco without using my insurance, and it's only $110 or whatever. I don't remember the numbers exactly. But once the patent went away and it came down, and now it's called Zetamimide or whatever.
Good job.
I can't pronounce it, but the cost went way down. And that's the generic for Zetia. I think my point is that you can save a lot of money just by going on to something like a Goodrx and going around your insurance sometimes because it's a lot cheaper not to go through your insurance. You may have to go to another location to do that, but it's just a thought.
No, Otto, I think we see a lot of that. I mean, I'm even going to say 5 to 7 years ago, I do a lot of talks in senior centers. Obviously now with the current COVID situation, a lot of the talks have been via Zoom. But 5 to 7 years ago, I was telling patients, really encouraging them, only go to one pharmacy. Pick your pharmacy, don't mix pharmacies, because really you want all your medications in one place. But the world has changed a lot in many different ways. And I think you bring up a good point, Otto, about, shopping for the best price. And a lot of patients find themselves in that position. You mentioned Goodrx. Goodrx is a website that actually helps you shop the price. And even patients with insurance are using it to get better prices on their medications. And while I do think it's very good, it has some caveats, especially if you have insurance and you have a deductible. Because when you go through something like Goodrx and you don't, and your insurance is not seeing that claim, you're not putting that money towards the deductible. And some patients will never even reach their deductible, and some patients will. So, I think, Rebecca, to your point in the very beginning, this is one of those complexities. I mean, we think first and foremost about how medications affect the body and the organs, and is it gonna treat what I'm using it for? And then there's this whole cost perspective of, how do I get my medications? How do I afford them? How do I pay for them? And it gets confusing, right? So
it's interesting, like what you just pointed out. If you do first have to cover your deductible, but once you cover it, I've gone online and my insurance company charges, I'll use round numbers for something, $80, and I go on Goodrx, and at Walgreens, the same place I would go to, it's $30. So you can go to the same pharmacist, but end up with a different price because of who you use. The whole thing is like, I don't understand this whole thing.
I mean, Otto, you're observing something that's a very real, I mean, I call it a problem, but
Yeah.
it's a very real situation that that we deal with, especially for seniors. With Medicare Part D, right? Back in December, you might have changed your Medicare Part D plan. And what I noticed when I was helping, people walk through this process is that you're right. If you fill at, one pharmacy versus another pharmacy, one might be a preferred pharmacy and one is a non-preferred pharmacy. They will still cover it, but it's at a different cost.
But it could be within the same pharmacy.
It could be within the same pharmacy,
That's what I've discovered. I mean, I get a lower price at Walgreens with Goodrx than I do with my insurance. And I don't get it. I don't understand the whole system.
There is definitely not a straight line anymore. I used to understand it. I feel a lot better than I do now. There's just so many variables. And some pharmacies are also now plan providers too. So of course they're going to be their own, preferred pharmacy. So when we look at helping patients pick their Medicare Part D plans, Part D is that prescription plan. Just, I know everybody here might understand that, but for those that are listening, if you're not familiar with Part D, it's the part of your insurance that covers prescriptions at the pharmacy. When we're helping people pick those, we're looking at, well, which pharmacy do you prefer? Some people are able to get in a car and drive anywhere and go to any pharmacy. And some have to stay with the pharmacies that are maybe delivered to them. Maybe they're in walking distance. Maybe somebody brings them there. So some people are really, I don't want to say stuck, but, they have to go to a certain pharmacy. And it's hard. I met a lot of people last year that really wanted to stay with some of their independent pharmacies. And it was going to cost them more. And it was a challenge for them, to decide, did they want to spend more out of pocket, or did they want to stay with the pharmacy and the pharmacists and the staff there that they know and love for so long. So it actually brings up emotional stuff too. I mean, and I loved hearing how committed so many people were to their pharmacies and pharmacists, because ideally that's, as a pharmacist, that's, what we set out to do, is make those relationships. So it's hard.
Yeah. I mean, and there is, of course, a convenience for using a pharmacy in a large chain, especially if you travel, or you have a kid up at school in a different state or a different part of, of the world, and you're able to transfer things. So there is, that convenience, but it's just so confusing. There's so many layers with, trying, between medications and adjustments and, like even this whole thing that, Otto has kind of discovered on his own. I mean, from the same pharmacy, getting a different price at different places. So it's just, it would be so easy if it was just like, could be mainstream somehow, but that, I guess
it's sort of like playing the lottery. You really don't know.
Yeah.
I always look and it says, okay, no cope, nothing. I don't have to pay anything.
Yeah.
The next time I look at something, it says I have to pay $80. I go to Goodrx, and many times it comes out like $30. So, I'm not one that's going to save $1 or $2, but if I can save 40, 50, sometimes I've saved $100 and $200 on medication.
I don't, now that you're saying that, sometimes what might be happening, one of the things that I think could be happening is that maybe it's a time, if you're hitting that, what we call the donut hole, where, there's a certain, in the beginning of the year, medications are covered, 100%. When you get to a certain dollar amount, the insurance asks for, more of an out-of-pocket cost from the patient. And then when you get through another like $1,000, they start covering it again. The schematic is very confusing, but I'm thinking maybe that's sometimes why you're noticing that, 1 month it might be, a certain price, and then the next month it goes up, and you're, sitting there wondering, like, it's the same medication. Why is it going up? And a lot of times it's hard, even as the pharmacist, to understand, everybody's different plans. It puts a lot of onus on the person themselves to know something that's challenging to begin with.
Right.
So
What's sad is that a senior, particularly, who may not be using a computer, probably will not discover that unless they have somebody helping them.
Right.
It's just not going to happen. So they're going to wind up taking the hit more than anybody else.
They should be
Yeah.
listening to Project Independence and you, and they'll learn a lot, right?
Say.
Well,
I was
actually,
just
I think Project Independence would help somebody with that part of medication management. They could check for you. The social worker or the nurse could check on the computer. For example, Goodrx. What would it cost me if I bought this through Goodrx as opposed to,
Yeah. Otto, you bring up such a good point about, the other people that are around to help patients. Obviously, like, I'm a pharmacist. One of my roles at St. John's University is not only do I teach at the university, but I am a pharmacist in a doctor's office. So I am with a practice out of Northwell. It's a primary care group of physicians and medical residents. And within the office, we have a social worker, we have nurses, and these are also people that, work to help patients, identify cost savings options. And the beauty of it is, if they don't know it, they usually know someone who can help. I also work with, many nurses that work within Project Independence, and I know that they're they reach out to myself and my other colleagues that do some of the same things that I do, looking for some of these things. The team of healthcare professionals helping one person, that one person might not know everybody, but there's usually a team behind them that's working towards, like, hey, where can this patient get this medication more cost effectively? Because we're very cost conscious on the side of when we're prescribing medications. I mean, just as a disclaimer, I'm a pharmacist. I don't prescribe medications, but, being in a place where there are physicians and nurse practitioners that are prescribing, we have to know if the patient is going to be able to afford the medication, because a plan on paper is not a good plan. The patient has to be able to get the medication and take it for it to help them. So if there's patients out there and you're finding yourself in a position where you're challenged, where you can't get your medication, ask if your pharmacist, your nurse, your physician, and they will find somebody to help you.
Thanks. You know what, Danielle, we have to take a quick break. This has been really informative. We'll be back with Danielle Ezzo, who is a pharmacist and an associate clinical professor at St. John's. You're listening to Project Independence in You, and we will be right back.
Take WCWP with you wherever you go with the WCWP app. Listen live 24/7 to all of our streams, all from one app. Plus, call the studios directly from the app and visit our social media. Download the app through the iOS App Store on Apple devices or the Google Play Store on Android by searching WCWP Radio, or visit WCWP.org for links. The WCWP app, available now on iOS and Android devices.
Welcome back to Project Independence in You on 88.1 FM and WCWP.org, Community Talk Radio. I'm Rebecca Miller, your host for today, and along with Otto Lohse and Christina Liu, the radio show producer. We're speaking with Danielle Ezzo, and she's just giving us a lot of really good information and even like recommendations. One of the things that you were saying, and Otto is you have to be like a self advocate. You have to advocate for yourself. And, Otto, as at his disposal, he is technology savvy, but there's a lot of people that aren't. And it's not just seniors either, because it's so confusing because of all the levels. And then, if you do have to call, which I know a lot of seniors do get on the phone, there's long waits, and, there is a lot of confusion. So it's so important just to be somehow to get as much information as you can. And, and I think key too, is really to have a very open relationship with your doctor, because your doctor is prescribing, and, sometimes their office staff should be able to help with some of this. I mean, and they're very busy today, I know. But, you can always, refer to your doctor's office. I mean, if they're the ones prescribing the medication and it's cost prohibitive, or, he writes for a prescription and you wind up getting a generic and you don't have any understanding. So do you recommend that too, especially for the older population?
One of the things that I recommend to patients is, have a notebook and write down your questions, because sometimes questions are big and they're urgent and you need them answered right away. And sometimes questions are small questions that you're thinking about, but you might not remember when you go back to see your prescriber, for your office visit. Also sometimes it's hard to get in touch with your physician or, your prescriber, right? I try to use the term prescriber because there are lots of different types of prescribers. There's doctors, there's nurse practitioners, there's physician assistants. But if you're really having a problem with a medication, I would say the first person to reach out to is the pharmacist. They may not be able to change anything on the spot, but they'll be able to give you that info. So, it's hard for patients, I think, to understand every little thing about the medication that they're on. But asking the questions, I think, is one of the most important things you can do, even maybe if you know the answer, but also not just ask the question, but ask the question to a healthcare provider. It's really tempting to go on Google. It's really tempting to ask a friend, and we get, instant answers that way, but that could just add another layer of confusion and fear. And sometimes what people do when they are afraid, they stop taking a medication, which that in of itself can cause a problem. So reaching out to a healthcare professional, especially if it's urgent, and getting some answers. I think the other thing, that's a big recommendation of mine is carrying around a list of your medications, an updated list of medications that includes the name, the dose, and how frequent you take that medication, both things that you're prescribed and things that you may take that are over the counter, right? Because we talk a lot of medications that are prescribed by a prescriber, but we haven't even touched upon the things that people may pick up over the counter to help with, those aches and pains that people have. There's also things like vitamins and supplements that, everyone thinks is natural, but a lot of those still have interactions and could throw off another medication. So, having an updated list, at least once a year, update that list. So if you're out there listening, this is a good time to do that update. January is always a good time to, reset everything. You might have had significant changes over the years or over last year.
You mentioned the words aches and pains just now. I'm hearing from a lot of people around me for a variety of reasons, pain management. And pain management, if you look on anywhere, you see 450,000 different things you can do to manage pain. Different creams, different patches, different over-the-counter things, medication, whatever. And you said earlier in the show that something works like oxycodone may work for one person. Believe it or not, it may not work for somebody else. And the whole topic of pain management is like a huge mystery to me. I don't think there's a golden answer, but what's your thoughts in terms of, like every doctor seems to have a different philosophy on how you manage your pain.
Otto, you bring up so many good points about, different Different doctors have different philosophies. I think it's also just a different approach to treating patients. I always say there are prescribing patterns. I think we have to take a step back. When it comes to pain management, there are different types of pain, right? There is pain that is sharp and shooting pain, and we call those things nerve pain, and that's treated very differently than like a pain coming from an osteoarthritis, pains in your knees or your joints, and so many other different types of causes for pain. There's what we call chronic pain that people are living with and likely won't go away, but maybe we can manage it and make it more, I can't think of another word, but manageable, but, making it more comfortable for a patient, but maybe they're never really in no pain. And then there's what we call acute pain, right? You smash your finger into a drawer, like that's going to hurt right away, but that pain's going to go away. And there is a different medication for every single one of those situations. And I think, understanding that, it doesn't make you understand the whole topic of pain management, but just knowing that there's different types of pain and different drugs that treat each of those types of pain. That's why there's so many answers out there, or so many, if you looked it up on Google, why you would find so much, or if you talk to the person, that might have something similar going on, maybe they're on something completely different. I think when we hear the term pain, we right away think of, those strong painkillers, like, you mentioned oxycodone. Those are very strong opioid types of medication that, while they may work, they may be too strong for patients. And those, of course, have their own side effects, causing things like excessive drowsiness, constipation, which now might need another medication to help treat that. So there's not one specific answer for pain. I precept pharmacy students, and actually my pharmacy students that are with me right now, we were just talking about a patient that had multiple sources of pain, both nerve pain, both chronic pain, happening in the same person, and they were on many different painkillers that all seem to be not even really working all that great. So as a pharmacist, I look at the drug, I look at the dose, I look at how often somebody is taking the medication. So it loops me back to the reason why, as a patient, it's important to carry those things with you. Because if let's say you went to go see a new prescriber, or you went to a pharmacist and you were getting medication from different places, if you were asking somebody to say, like, well, what do you think about my regimen? They would need all of that information really to make a very good assessment, and really to determine if something was not optimal. Maybe something could be done better. Maybe it's a specific drug, that's we think is the best, but maybe there's something that's more common and actually turns out better for you. It's so individual. It's
not just prescriptions either, right? Like there's a lot of people trying to sell stuff for pain management. If you go down an aisle in any drugstore, you've got 100 different things you can pick from, between sprays and patches, and I mean even like Tylenol or Advil or whatever. And everybody's going to fix your problem. There's no question about that. So that's why, to me, that's like one of the biggest areas that in your world, to me, is at least one of the, if you go through pain, it's not a fun thing. And people really want help when they have pain. So to find people who can really help them with pain and understand, like you just said, some things that I never thought about, a shooting pain is the nerve, whatever. You really need to have somebody who really listens to what your story is, and it really has a broad knowledge of what these tools are that can help minimize the pain. And finding that person, to me, is not an easy trick.
No, it's not. Otto, well, I'm sorry, Rebecca, go ahead.
No, I was agreeing with Otto. Again, it's just like I keep feeling this advocacy yourself. You have to be so on top of everything. And but this is like, I agree with Otto. I mean, knowing that there's different medications for different types of pain.
Yeah.
I did have a broader question. I just like, is there a limit? Like there are seniors that are on so many medications as we get older, maybe it's diabetes and cholesterol and blood pressure, and you have other arthritic medicine. And, as we get older, all those things to the point where you're, taking so much medicine. I mean, is there just a limit where, like, is the body going to ever just reject everything and not metabolize it correctly because there's so much medication being taken?
Yeah, Rebecca, that's a very common question and concern from patients, especially people who are just diagnosed with things, and they go from taking maybe nothing to 4 or 5 medications at a time. I mean, there are always max doses. There are always, overdoses. But this is why it's so important to have healthcare professionals and really a pharmacist on the team somewhere looking at the doses you're taking, because what you're saying of oh, it's the 7th medication that my body is taking in, like my body's just going to reject everything. Like, that doesn't necessarily happen, but one medication could affect another medication. There's these balances that have to happen, right? And that's really where, the role of the pharmacist on the team, in the community, maybe in the hospital, they're going to make sure and look at drug interactions. If I start the second drug, does it throw off the first drug? And so on and so forth. It also determines how the body works, right? You can have many different people on the same medication, but maybe one person has kidney problems. Maybe one person has liver problems. The body does metabolize and excrete drugs differently depending on how your organs are functioning. So, it's such a, taking medications, even though, many people could be on similar regimens, it's so unique to the person.
Right, right.
One of the things, yeah.
One of the things that you just talked about was a question that I had, because, like when you hear of, ibuprofen or acetaminophen, and one goes through the liver and one goes through the kidney, and, that's very confusing too,
Mm-hmm.
and how they do all medications go through either or, do most go through a different organ?
So I would say, as a blanket statement, most medications go through either or. Yes. Okay. The body, the liver is mainly the place. It's like the engine that starts metabolizing the drug, right? I mean, if you even just think of the course of how we take medications, think about a tablet of Tylenol. You have to swallow the tablet. It has to go into the stomach. It has to break down. Right? So it first has to be absorbed into the body. Then the body has to distribute this to where it's supposed to go, right? The site of action. Then usually it's the liver that starts metabolizing it to start getting rid of the medication. And then typically it's the kidneys that help excrete the medication out of the body. That whole, that whole process is where at every single one of those points, there are so many things that it can affect any one of those processes. So, the simple answer is yes, every drug has to go through those, 4 processes. I think, when we say things about, how a patient needs to be their own advocate, one of the things that Otto said before was, tell your story. Like, everybody needs to know their medication story. Mm-hmm. Why are you taking something? It's not the patient's responsibility to know, does this affect my kidneys or my liver per se, but they need to know that they're taking it and why they're taking it. And getting those, what we call a medication checkup. Is this drug still good for my body a year later, 2 years later? I meet a lot of seniors that say, oh, I've been taking this medication, longer than you've been around. And it's like, well, your body changes. The drug might not have changed, but your body changed, right? So it's important to, keep up with those appointments where you're getting your lab work done, and just kind of seeing if that medication is still working the same way and is it safe for you, right? We think about safety and, does it actually work?
I had that experience with the statin, which we can get into after the break, I guess.
Right. We have to take a quick
Right.
break. Thank you so much. We are listening to Project Independence in You on Community Talk Radio 88.1 FM and WCWP.org, and we will be right back.
WCWP is your home for great music and great conversation. You'll find all that and more on WCWP.org. Listen live on the web, check out the lineup, subscribe to podcasts, and stay up to date on the latest station events. Get in touch with us and let us know if you like what you're hearing, and find out how you can support or get involved at the only community public radio station serving Nassau's North Shore. Plus, sign up to get a free bumper sticker. It's all online at WCWP.org.
Yep. Welcome back to Project Independence in You on 88.1 FM and WCWP.org. I'm Rebecca Miller, along with Otto Lohse and Christina Liu. We're speaking with Danielle Ezzo, who is your pharmacist. You're also an associate clinical professor. So we're, very happy to have you here. I mean, we're just throwing the questions at you, and you've got the answers, which is so great. It's so great to have you on. Over the break, we were talking about when people take a lot of medications, for whatever reasons, they have multiple conditions going on, and vitamins and medicine, and can you just go ahead and put all your meds in your hand and drink all at once, or one after the other, or because especially if your prescriptions are for one a day. Obviously, if they're for multiple times a day, or they're, more kind of, I guess, diabetes related and injections and that kind of a thing. But if you have a lot of medications, if you're taking blood pressure and cholesterol and whatever other medications you're on, can you take all of the medications at once?
So, I feel like most of my answers, when you ask these questions are, it depends, right?
Right.
For the most part, yes, but there are medications that could potentially have interactions if they're taken at the same time. When you're prescribed your medications, you usually get, take one tablet, like you said, take one tablet in the morning. Or sometimes it says take one tablet once a day, which makes it confusing. Like, what's once a day? Is it in the morning? Is it in the afternoon? Is it in the evening? Do I take it with food? Do I take it without food? And every drug, has a little bit of a different reasoning. I would say at least one time you need to ask that question of, can I take all these medications at once? And a pharmacist will be able to tell you if it's yes or no. So I don't want to give a blanket statement that yes, it's okay.
Right.
But if medications don't have an interaction of, attaching to each other in the stomach, yeah, you could take them at the same time. They know where to go, right? They have a pull to a certain area of the body. As long as they don't have the chance of binding to each other when they're in the stomach, for the most part, you can take them together. Some medications have to be taken alone. Earlier in the show, I talked about Synthroid, the generic is levothyroxine. That's a medication that needs nothing in the stomach. No other medications, no food, because anything in there with the medication can block the absorption, and then it's not going to work as well for somebody. So it does really depend. Like, that's another question patients have to ask. Bring that list to your pharmacist, and even that question of, can I take these all together? It would be really easy for me to take them all in the morning and then just forget about them. And the pharmacist will help guide you whether that's a yes or a no. I know many people that take 6 or 7, sometimes even more medications all at once, with knowing that those don't have that interaction. Very often I tell patients, you could take these 5 together, but this one has to be at night. It has to be separate from the others. And it's hard to give that blanket statement. So it's just another area where I would say, ask those questions. That's probably a specific question for a pharmacist and not necessarily a physician, because they're going to look for a pharmacist to answer that question.
You just said thinking about a lot of things always, but when you take blood pressure medication, you hear about people's blood pressure goes up in the morning, but that may not be true for everybody. So I guess the question is, in general, when should you take blood pressure medication as an example?
I don't know. That's I think that's something that is not necessarily controversial, but over the past few years, there's actually been some studies to look at that. Is blood pressure medication best taken in the morning? Is it best taken in the evening? For the most part, most people take it in the morning. But if you're finding that your blood pressure is spiking or going really high in the evening, sometimes we try moving the blood pressure medication to the nighttime to see if that helps before adding on more medication. Most prescribers really, and this is, when I use the term optimizing drug therapy, optimizing how a drug works, I used that terminology before. And this is one of those examples. Before adding on more medicine, we want to make sure we're doing the best we can with the one, maybe the two that you're on. My husband gets sometimes frustrated with the terminology of, well, let's try it. He says, what do you mean try it? Don't you know if it works or not? And again, I try to explain to him, it works differently for different people. So I think that my natural instinct would be to tell patients to take blood pressure medication in the morning. But if you're still seeing spikes later on in the very late evening, well, let's try moving it to the evening and see if that helps.
Right.
In reality, some people do need to add medications on. Blood pressure is an area where our guidelines, which are, the body that tells, that has done all the research to tell us what drugs to use, most people need probably 2 medications to control their blood pressure. And sometimes those 2 medications are combined in one tablet, and sometimes they're separated. I think a point that comes up with blood pressure is that if it's a water pill or a medication that helps get rid of some of the extra water, it should definitely be taken in the morning because nobody wants to wake up all night and have to use the bathroom. So, again, even within that group of prescription medications for blood pressure, it really does depend what blood pressure medication you're on. For some people that have really complicated blood pressure issues, sometimes we tell them, well, take 2 medications in the morning and 1 in the evening to help sort of balance it out. If they're once a day medications.
You said earlier the words body changes. I've had several experiences in the last year, personal experiences, where one had to do with statins, Pravachol, Pravastatin, where I was taking it for God knows 30 years or more, and I was taking a high dosage and my cholesterol numbers were very low, and I started to get aches in my shoulders, and I do shoulder exercises pretty often because I've had problems in the past. So all of a sudden, like in the middle of the night, I was starting to get some pretty bad pains in my shoulders. So I naturally do my Google thing and I look up and I understand that statins could cause joint pains and joint problems. So I figured, okay, I will talk to my doctor about that. And I did. And we cut the medication in half. And all of a sudden, my shoulder pains have gone away and my joint pains have gone away. Now, we do have to check my cholesterol numbers as a result of this in the next go round, but that's just an example. I had a second experience with blood pressure medication where my diastolic number was going, and I've been on blood pressure medication for God knows how many years. My diastolic number was going way down. And I'm talking like in the 50s, low 60s. And I'm like tired because, I had no zip. And I mentioned that to the doctor. And she changed the medication and actually reduced my medication. And all of a sudden, my numbers I did go through a curve, we watched it closely where they went up. And combination of watching and reducing the medication, now my diastolic is in a reasonable range. So I feel halfway decent because I think one of the problems is, you can make your blood pressure go down to, 105 to 60 and be
terrible.
strong, but you have no energy. So
Right.
your quality of life stinks. So what's the point?
Yeah.
My point of this whole thing is pay attention to your own body and your own things that are going on, and tell the doctor.
Agree.
And maybe they, like I do check my blood pressure periodically, not every day, but I do with one of those wrist things.
Yep.
And I write it down, and as you pointed out, and I'll go to the doctor with these numbers and show them, the history for the last 3 months or whatever. And it's very helpful. And frankly, the other thing that's a new toy is this Fitbit business,
Yeah.
which gives you
It
your
tracks some of
resting
those
heart
things.
rate.
Yeah.
And that's what was the trigger that got me to thinking about the blood pressure, because my resting heart rate was like I was an Olympic marathon runner.
Wow.
It was in the low 40s. But
Wow.
that turned out to be, you look it up and it says, oh, you're an Olympic, athlete,
Yeah. That's
I
too
said, I
low.
don't
If
feel
you're
like an
awake,
Olympic-
40 is too
Yeah.
low.
Right.
Yeah, I
even if
don't
you're
feel like an
sleeping.
Olympic athlete.
Otto, I think one of the things, as I hear you talking, any sign or symptom, especially as an older adult, but, Rebecca, like you mentioned before, it goes for everybody that's taking a medication. Anytime your body feels a little off, you need to bring that up to your prescriber, because a medication could be the culprit. And not just to your prescriber, but to your pharmacist too, because it could be a side effect of the medication. And it doesn't necessarily mean that the medication is bad for you, but like you mentioned, maybe the dose needs to be changed. Your conversation about those statin medications, right? Things like atorvastatin, which is Lipitor, or Crestor, which is rosuvastatin, and there's 4 or 5 others. That's a common side effect to have those. Many people describe it as joint pains. It's usually the big muscles that are surrounding those bigger joints that start to get affected. And many times reducing the dose is what helps. And you're right, when we reduce the dose of a medication, we do have to look at the numbers and, like you said, check the cholesterol to make sure we're still hitting some of those targets.
Right.
Because anytime we, change a medication, yes, it's going to have an effect on how it works, but we can't have people having side effects and not change those medications, right? Like that's where we can't jeopardize safety for efficacy. Efficacy meaning the drug actually works. But patients have to bring those things forward.
Yeah.
So
I was just going to say, I had a personal situation that still leaves me kind of uncomfortable, where I had a doctor. I have high LDL. My LDL is elevated. My HDL has always been over 100, which is very good.
Yeah.
So my
Yes, that's very good.
ratio is always excellent. I have this terrific ratio, but the cardiologist doesn't like the LDL. I even had a CTA scan. I have no plaque. I have no calcification. I've got, nothing going on. But, he just thinks it's like the worst to have this high LDL. So I started taking a medication. And then, when I go for my regular checkup, my doctor is like, he wanted to increase my Crestor even more, the cardiologist, to get my LDL lower, even though it did come down. And my family doctor said, your ratio is great. You have no other cardiac issues. I think you're fine staying at 5 milligrams.
Yeah.
So here I am, kind of like in between this, like this new way they're thinking that, LDL is kind of like it goes above every other number. You should be most concerned with that. And then my other doctor's like, you have this great ratio. You don't have, so you kind of have to, like, what do you do in that kind of a scenario?
I mean, first off, it sounds like you're in good hands, right? You have two,
Okay.
two physicians really, really thinking about your situation. A cardiologist is, when it comes to cholesterol and everything surrounding cholesterol, or the heart, I should say, a cardiologist is going to treat aggressively, right? There's aggressive treatment, and then there's what we call conservative treatment, which is we treat, but maybe on the lower end of things. Both Otto and you brought up, your lipid levels. When we think about using statin medications, these medications that, yes, we know they're for cholesterol, statins have many other benefits. And we look at the cardiovascular disease risk score. How likely, and this is going to sound very technical, but it's how likely, it's a score that we can calculate. Right. How likely in the next 10 years are you to have a heart attack, right? So we want to reduce that risk. It has, and your cholesterol numbers are a small part of it. Your age goes into it, right. Whether you smoke or not, whether you have diabetes, whether you have high blood pressure in addition to high cholesterol, and we get a score, and it comes out in a percentage. And anything that's over like a 7.5%, we treat. Our guidelines tell us to treat pretty aggressively. Right. And for many, many years, I mean, pharmacists and in medicine, we sort of have this mantra of start low, go slow, don't stop too soon, right? Yeah. So we can work our way up. But it changed specifically in the area of, treating with the cholesterol medications, to start high and reduce if we have to. Only because, cardiovascular disease is so serious. And right. You get bigger benefits if you use those bigger doses up front. But again, we have to, monitor and make sure you're not getting those side effects. So it's
how do you get that score that you're talking about?
So, I mean, not that I want to point anybody in the direction of Googling it, but it's ASCVD score, right? And
I'm sorry, say that again.
ASCVD. So it stands for atherosclerotic cardiovascular disease.
You said S, right? AS.
Yes.
CVD. I can share that. I have to give the disclaimer, like this is something that you need to talk to your healthcare professional about. But you can calculate the score. You might not know what that means, right? Because there's a lot of things that you might not have all the numbers that you need for it.
Right.
But again, a question when you go to your prescriber, ask them, because they're probably looking at your ASCVD risk score. Rebecca, that's a good question for you to bring to them.
Right. I had that because I had all the tests done, and because I actually had a cardiac ablation a few years ago, which was very successful, and all is good. But my score was less than 1% chance of having cardiac disease in 10 years. But still, it's this LDL. He just, and I was like, okay. And when he started me on the medication, it knocked me out. It just like I was a zombie. Everything hurt. So I wound up going to my family practitioner, and he just said, just go on this 5%. You everything. Yeah. You have no risk of heart disease. At least for 20 years at this point.
Right.
But so I did go on the lower amount, and still my LDL is probably higher than my cardiologist wants it, but everything else is so healthy. So it's so like you're I can imagine, for me, it's kind of, I'm still not sure what I should be doing. Like I'm almost afraid to tell my cardiologist, but I don't, I mean, I don't even see him anymore, but for me, it's confusing. And well, if I'm so healthy, why do I need this and the LDL? But I can imagine for a senior too, like,
Oh my gosh, I know.
Do you the cardiologist, if you have a heart condition, then, a serious heart issue, I guess it's the cardiologist, but if it's like a general, I don't know, you
well,
just
doesn't the triglyceride come into that?
Question. Yep.
Also,
Otto, you're right. That's another part of the cholesterol panel. We talked about, Rebecca mentioned LDL and HDL. Triglycerides do come into it as well. The LDL, you're right, Rebecca. I mean, if it's over a number of 190, it doesn't matter what your score is. Any physician's going to probably want to start, a statin medication to get that down.
For the LDL, oh my God, that's really high. On my side.
That's very high, right? That's very high. I think the question for you to ask, the best question that I would say to ask is, what's my risk versus my benefit, right? And if what risk am I at a higher risk of being on the medication or at the higher dose of the medication, or am I on a higher risk of not being on that higher dose, and see what that conversation looks like.
Because
I like that. Really, it's very clear just from this conversation that not everybody fits in the guidelines that are put forward. There are certainly people that, really could fall on either side. And I think when I get to that point, I really ask that question about what's the bigger risk versus what's the bigger benefit. And that's the way I'm going to go.
That's the greatest advocacy enough for, our seniors. Those are the things that you should be asking too. It's so important. We had a doctor on, and he was talking a lot about the relationship he has with his patients and how important that is, to be able to have that kind of rapport, not just kind of in the door, out the door, take this,
right.
You really need to be able to talk to your doctor and he or she needs to listen. Yeah.
Which is difficult nowadays because they're all on the clock.
But you know what, Danielle? Can you believe we're done? It's been an hour. You've provided, once again, such tremendous information. And, it's good basic stuff, too. And it's like everything you have said and the advice you've given, really, I think we could all use, no matter what age. So I'm sure we'll have you back. You've been listening to Project Independence in You on 88.1 FM, WCWP.org.